the presentation. So I will start on anterior hip, moving from lateral to medial. Then, if we have time, move to the lateral part and the posterior part. So first of all, the first anatomic landmark we have seen before is the anterior superior iliac spine. Okay, we search for it at this level, and immediately we see the two muscle taking origin from here. Okay, one is the sartorius. Sorry, this point. One is the sartorius, and the other one is the tensor fasciae latae. Okay, underneath we have the rectus femoris with its aponeurosis. We've seen that before. Okay, so basically this is our starting point. If we move laterally, we see appearing the tensor fasciae latae. If you move further lateral, we see that from the posterior border of tensor fasciae latae, there is the iliotibial band, okay, that bridge over the gluteus medius, gluteus minimus, and move posteriorly to reach the anterior margin of the gluteus maximus, okay. So we see before that both the origin of the tensor fasciae latae could be involved by tendinopathy. We have seen also that the fasciae latae that you see here, just adjusting a bit the images, this is the point where you have insertional, and you can have an intensophyte, you can have a tendinopathy. But remember that the fasciae latae don't only could be involved by this kind of insertional pathology, but in case of lateral snapping hip, you have to move. Is useful to follow fasciae latae even at a lower level, just close to the trochanter. Okay, so this is the fasciae latae. Always you see that is a bit thicker in this point, and sometimes when you have a tendon alteration on the fasciae latae over this point that corresponded to the lateral, the so-called lateral snapping hip, you can have a thickening alteration up to this point. So when you look to the fasciae latae, look at the insertion, look where it go close to the trochanter at this level, and of course check also level the knee. Okay, because there is the so-called runner knee. That is this mechanism is the same as the lateral snapping hip. Okay, is the fasciae latae that is scratched against the lateral condyle. If we go distally, we see here the fasciae latae. Here, going very close to the lateral condyle at this point. This is another point of possible pathology of fasciae latae. We go back, okay, and we look for the lateral femoral cutaneous nerve. Okay, first of all, you have to look for the inguinal ligament. So you check for the anterior superior iliac spine and orientate the probe toward the ligament, toward the pubis, toward the pubis tubercle, and you have a very superficial this fibrillar structure. Okay, and as you can appreciate here, it's not very easy to find moreover, if there is no pathology, to find the lateral femorocutaneous nerve while piercing the ligament, also because we don't know if it is here or more distal. So, as I suggested you before, the best thing is to look for first of all adjust the image, and to look for the sartorius, and in particular for this triangle of fat tissue just in between the tensor fasciae latae and sartorius. And you see that there are some small fibers in this point, going up, in this case is very close to the iliac spine. Just to be sure, if you have availability to have a very high frequency probe, is not necessary this one, the 22 megahertz probe, but even an higher frequency probe, you can see even better the anatomy in this area. Again, our landmark, the fat plane here, and you see that there are these small fascicles that go together, and this is the nerve. Okay, you see that there are some fascicle here, some fascicle here. It's quite dispersed, and the anatomy is variable. But if you use the technique, this technique, to search the nerve at the level of the fat plane between the sartorius and tensor lata, it's quite easy to find it and follow backward. Okay, and this you see, and this is where it go through the ligament. Okay, this is exactly the place where it go through the ligament. You recognize the fascicle, and this is the insertion of the ligament. And we try to obtain a long axis view. Again, we go back. This is the nerve, and this is the long axis view. No, just to confirm that there is no swelling where it go through the ligament. This is the image. Okay, from ear to ear. Of course, it's not necessary to have a high frequency probe to the meralgia paresthetica. Sometimes is useful to have this probe to detect the nerve, normal nerve, but of course, when you have the pathology, even with the lower frequency probe, you see the nerve enlarged as an hypoechoic spot that could be easily visible. Okay, so and moreover, you have the association with the clinical. Now, we look for the other nerve of the groin area. Okay. And this, for the lateral femorocutaneous nerve, the anatomy is variable. For the genitofemoral, ilioinguinal, iliopogastric is even more. So, what are the landmark you have to find? Basically, you have to find the three-layer structure on the abdominal wall. Okay, and that means that you have. Look at the probe position, just 45 degrees respect the position for the femoral nerve, and is perpendicular to the line from the anterior superior iliac spine to the pubis. Okay, and if you stay at this level, it's not easy to recognize. If you stay too close to the iliac spine, it's not easy to recognize the three-layer structure. You have to go a bit more cranial, and in this plane. This is the plane where you have to look for the nerves. This is you remember that there is also vessel in this area, the circumflex vessel of the iliac crest that they run in this area, and this is the space where you have to look at the nerve, and you see that this one in particular seems to go perforate and go cranially. Probably is then going upper part in the upper space. Probably this is the iliohypogastric. So, yes, because the one go more superficial. The ilioinguinal instead usually go around the inguinal canal. Okay, this is the femoral artery. This is the content of the inguinal canal. And within all this fascicle, you have also some fascicle that could be related to some of the branch of the iliolinguinal nerve. But of course, the concept is that if I want to block, if I want to see if there are any alteration, look for this interface. Okay, when you check this interface, then you can move proximally or distally, and to see if there are some branches maybe entrapped in some scar tissue of this area. Okay, because basically This is the common point. Then from this point, the ilipogastric go immediately superficial to innervate the anterior muscle wall, because there are also motor branches. Innervate the anterior muscle wall and then the skin. And the linguinal go into the canal. Okay, so look at this point and look at any alteration along the course, along the path. Okay, in this part, you see going backward, this fascicle, this small fascicle probably is related to the, just here is related to the ilipogastric, piercing the obliquus internus and moving superficially. Okay, this is what you can see about this nerve. We can try just with a superficial probe. If I level the inguinal canal, we are able to see something more. But so we can check this structure. This structure you see here is the inguinal ligament. You see, with this probe you see it very well. Okay, you can follow distally. You can follow distally until you recognize here there are some vessel moving toward the pubic area. Okay, this is the spermatic cord. Okay, that is much magnified at this point, and you see that, for instance, this one could be perfectly one of the branches of the ilioinguinal nerve. Okay, but of course, is the most important thing is to know anatomy, to know the region, and to know at least two spots where to look for them. A level of the spermatic cord or the round teres ligament in the woman, and a level on the interface between obliquus interne and transversus abdominis. If you look at this image, you understand why, in case of herniorrhaphy, in case of hernioplasty, you can have this nerve, small nerve running just above the cord, could be easily injured. There are different fascicles at different level. For instance, this one, all the fibrotic tissue, one here, all this area could be involved in fibrotic scar tissue. Okay. Now, up to now, there are questions about this nerve. You can. Yeah, well, not personally, but with the anesthesiologist, very often for the herniorrhaphy perform the block, and the spot where they aim are the interface between the transversus obliquus sternus. This is your main landmark. Okay, main landmark to perform block. To see the nerves, you have to look for there, and then along the inguinal canal. Moreover, for the diagnostic purpose. For injection, there are no other spot than this the plane. Okay, you aim it to the plane. Injecting there is you block all the nerves basically. Okay. Then we go back to the lower frequency probe, by which we study the next structure, that is the iliopsoas muscle. Okay, so in transverse plane, the place where I suggest you to start is this image, and you are at a level the pubic ramus. Okay, is the best where you can see the typical anatomy of the iliopsoas complex, where you have the psoas, part of the psoas muscle, the tendon, the medial psoas tendon with the part of the muscle, the medial component of the iliacus and the lateral component of the iliacus. If you go more distal, sometimes you see the other aponeurosis could be related to the infratrochanteric muscle that could be at this level, and but of course it's an accessory under that is interesting only to explain the expansion of the bursa, because it's you see now the psoas tendon is very close to the joint, and if there is a communication, there is a ganglion cyst or whatever, this move one part move medially to the nerve, the other one if move laterally quite often as go inside this interface. Okay, this is also a good view to check any sign of impingement. You know that is described the ellipse, the psoas tendon impingement, that where you have alteration of the acetabulum and the labrum due to the action of the psoas tendon at this level over the labrum. So it's a good point to check this area. For the demonstration on the snapping hip, again, go back to this configuration, is the best one. And you have to put the bone, the pubic rami, exactly horizontally. Is the best way then to observe, okay? So you see all the anatomy of the complex well displayed. Once you do that, here, you grab the leg and start to move. Here. Exactly, thank you. Move up. You see? There is the psoas tendon. You pay attention to keep the psoas tendon hyperechogenic. Moves up, go up, go up, go up. I'm doing a work with the tilting the probe just to keep the tendon hyperechogenic, okay? Here, you have to put a maximal flexion, okay? Just to receive the snapping feathers. Then you start to go back like this, go back like this, go back like this, and always stabilize the probe and relocate the leg, okay? In full extension, the leg. Okay, you see? As a little snap, okay? Have you ever felt a snap in the hip? No. So, well, it is quite frequent. It's just to demonstrate that the snapping hip, the anterior snapping hip, not always is symptomatic. The patient could not perceive it, could perceive it, but without pain. The important thing is to demonstrate with this maneuver, which is the grade of the snapping, and moreover, if there are any underlying causes, as you've seen before in the presentation, any ganglion cyst. Okay, so moving further medially, we have the neurovascular bundle, and this is a very good image to see, where you see if I move proximal is a bit more difficult. Here is the best. Okay, you see very well the femoral nerve, which we are just distal to the inguinal ligament. You see the femoral nerve with the fascicular structure is not easy to perceive the iliopectineal arch, but is at this level separated the two lacunae. This is the femoral artery, this is the femoral vein, and this is the pectineus, okay? Pectineus muscle. And when there is a patient complaining pain, moreover if female, go a bit up here and ask to perform a Valsalva maneuver. Try to do Valsalva, okay. You see the vein, the femoral vein enlarge. This is when the femoral vein enlarge, you are sure that there is no femoral hernia. On the contrary, when you ask to perform a Valsalva maneuver at this level, you see or a bulging of fat tissue, or you see that the vein doesn't enlarge. This is a sign of the presence of hernia, okay? So it's just two. And remember that you have to go a bit more cranial. So you see the pectineus here, you go more cranial respect to the pectineus. This is the possible porta of the hernia, okay? Then, if we have seen the pectineus, underneath the pectineus, we have this muscle, okay? And moreover, we have this plane. This is the obturator externus muscle, okay? And if you go distally, if you put the probe in transverse plane, if you put the probe in transverse plane, you have to adjust the depth. Okay. Thank you very much. Okay, this is the area where the obturator nerve, obturator vessel come out. This is the level of the obturator foramen. Okay, this is the image you have to search, look for. This is the pectineus. This is the obturator. Okay. Now, if we go more distal, we see very well the typical anatomy of the adductor that allow us also to recognize the divisional branch of the obturator. So, pubic rami. Anteriorly, we have the pectineus underneath the obturator. Just anterior, we have adductor longus, adductor brevis, and adductor magnus. Okay. If we go anteriorly, we go distal, we see that at level of the aponeurosis, there are some fascicles above ear and ear. This is part of the divisional branch of the obturator nerve. This is the posterior branch. Anterior branch run ear, posterior branch run ear. Okay, and we can look for it also in longitudinal axis. We see even better. These are the anterior divisional branch. These are the posterior divisional branch. Okay. Indeed, at this level, it's not very useful to look for these branches because the area of the pathology, as I told you during the presentation, is usually at this level, very proximal, where you have there is also the obturator artery. This is where you have a kind of all the causes I told you before, maybe bone alteration, bone fracture, whatever, all the obturator hernia. This is the spot where there are more possibility to look for pathology. Okay. There are some case report, but not real study in literature that say that there is the nerve injury. This is the anterior branch, may occur also when you have a huge alteration, huge injury of the adductor. But of course, is as in this case, not very relevant to have the fact that you have pathology of this nerve when you have an injury adductor. Instead, the pathology of compression syndrome at this level is much more significant, as you've seen before. While we are studying the adductor, just to show you a couple of things, you'll remember that. Well, I guess that you know perfectly how to check for the insertion. Just remember that the most insertion you see here, this level, is from the adductor longus. Okay, the other components of the tendon doesn't have much this here. This adductor longus coming here. The other tendon has more muscular attachment, the brevis and the magnus, and the most tendinous part is from the adductor longus. And then, of course, there is the aponeurosis of the rectus abdominis pyramidale just here. Okay, but this is nothing of specific. The only thing to study the adductor muscle, this is the correct position on the leg. Okay, so in extra rotation and abduction. Instead, if we want to check the distal insertion of the psoas muscle, the best position is to put the heel over the knee, like this. Okay, and when we the probe. Okay, when we do like this, the lesser thank you very much. The lesser truncator is really well exposed. Okay, look at the probe. Is exactly aligned with the torso patient. Okay, so we have leg in this position. Placing the probe in the femoral triangle in this position, we recognize immediately the insertion of the lesser trochanter with the insertion of the psoas tendon. Okay, notice that the part of the muscle inserted here instead is the lateral head of the iliacus muscle. Okay, but of course, when you have a pathology, the most involved is the tendon of the psoas with the accessory tendon of the medial part of the iliacus muscle. okay? And other than abortion, remember that could be common in a runner to have some alteration at this point, or even if you see, even commonly, if you see some alteration in this, could be kind of osteochondrosis occur in a young patient when maybe a young soccer player that had increased traction over the tuberosity, and even when they are adult, it results in some fragmentation, something like the Osgood shatter, that may also occur. And okay, like this. This is all more or less all the anatomic demonstration for the anterior hip. Do you have question for that? There is something that you want to see specifically? No? Okay. Saphenous, yeah. Thank you very much. That's a good occasion to describe the anatomy of the femoral nerve. So we go back to the saphenous, to the femoral nerve. Okay, if we go distally, here we're still able to see that. We're still able to see that here. Then here you see it started to disappear. It started to divide many fascicle. Okay, and we try with a bit more superficial probe. I use the 24 because this is too superficial. Okay. 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 Femoral nerve here. Okay. Until here is a compact structure. If you move distally, you see that there are some fascicle going more medially here, and some fascicle go more laterally. Okay. The lateral one go to innervate the. You see this lever first. This one. The lateral one go to innervate the rectus femoris, and the rectus femoris and all the muscle of the quadricep. You see, this is the rectus femoris. You recognize that, and the vastus intermedius, like this one, or the vastus lateralis. So basically, are all muscular branches. Instead, if we go back, there are some branches that go medial. The branch that goes superficial to the femoral artery, here, this one is the saphenous nerve. So we have the sartorius muscle with the femoral artery. We'll look for the saphenous nerve here. Okay, just between sartorius and the artery. You understand, if there are intervention over the femoral artery, you can have some alteration that cause pain to the saphenous nerve that may irradiate until the leg. Okay, notice that there are some other branches here. This one are the branches for the vastus medialis. Okay, that you recognize in this point. And you go to innervate the vastus medialis, and in case of injury this branch, you have selective atrophy, of course, of the vastus medialis. If you follow up, notice that superficial to the sartorius, you have these small branches. All that hyperechoic area you see here are small branches, partly from the femoral nerve, but some of them. You see, go up, look where they come from, or this is an infernode, go very superficial, and they come from the genitofemoral. These are the femoral branches of the genitofemoral, so very superficial, okay? As I told you during the lecture, the sartorius is always a great landmark for all kind of nerve. And And of course there is also the femoral cutaneous nerve, anterior femoral cutaneous nerve, but they are less important from for diagnostic point of view, are much more important for anesthesiologists who perform a selective block. Okay, just regarding saphenous nerve, just want to show something more to complete that a possible site of entrapment of the saphenous nerve is at the level of the pes anserinus. Is very rare, but because basically the saphenous nerve becomes superficial in between the sartorius, the gracilis. Okay, this is the sartorius here, and just before becoming a tendon. Okay. You see, these are the different components of the pes anserinus. This is the sartorius. This is the gracilis. The most posterior, sorry, a bit more gel. The most posterior is the semitendinosus. Okay. Okay. And the saphenous nerve becomes superficial, just passing in between the nerve. This is the saphenous nerve. I move backward, here, and this is where go passing between the gracilis and the sartorius. Okay, this is the saphenous nerve. In this point could be entrapped when it pierces the fascia. Okay, just to let you know, when you have patients that complain paresthesia on the medial aspect of the calf and the lever of the medial malleus, where to look for the saphenous nerve pathology. And of course, remember the saphenous nerve run very close to the saphenous vein. Okay, so in case of intervention, these are small branches for the saphenous. In case of intervention on the saphenous vein, for the varicose vein, this could be an area where there are some cicatricial tissue, some scar tissue that could cause an entrapment on the nerve, the consequent pathology. Okay, you have to keep the probe very light to not compress the vein. You see this, for instance, these branches, the saphenous, go very close to the vein in this point. So this is a possible site of scar tissue when you have the intervention over the saphenous vein. Okay, and the last thing always over saphenous, that there are many interesting things. You see, this is the medial collateral ligament. Okay. And you see this fascicle here. We can check with the more superficial probe. So this is the medial collateral ligaments just here. If we move up, we see that there are some fascicles just here, and this is a clinical relevant. This is a branch of the saphenous nerve that is clinical relevant because could be entrapped, could be damaged when you have a knee surgery. Okay, this branch is this is a good landmark to look for it. And if we move backward, you see it that we can follow it backward at this point, but the most important point is close to the medial collateral ligament. This is called the infrapatellar branch of the saphenous nerve, and when you have knee surgery, it can be damaged. Moreover, in case of arthroplasty of the knee joint, with some the placing of the, you can have damage of this nerve, and could be caused really in the really important pain around this area, the typical neuropathic pain. So this is interesting to look for that. This is interesting to look for that and to block in case of untreatable pain. Okay. Yeah. Yeah. At the beginning, I show you it again. Sorry? Yeah. Could be where under the sartorius there is there are many nerves, many fascicles, and the saphenous nerve is the one between the artery and the sartorius. You see very well on this point, okay? And of course, there could be some pathology, but usually or a neurosheath tumor, so your neurinoma, or the most of cases are related to surgery in the anterior canal. That in the nowadays the surgery of anterior canal is much more frequently endovascular, so the chance decrease. Okay, but when is open, the chance of get a neuropathy of the saphenous nerve at this point is much more significant. Okay, we have it here. Then of course here, and then of course it releases some fascicle. This probably is the infrapatellar branch going up, but of course it's not easy to follow. The most important is to find some landmark, and for this nerve, for the infrapatellar branch that you see here, the main landmark is the medial collateral ligament, because medial collateral ligament, just on the femoral attachment here you find it, and then you can find you follow it up here. You can follow it everywhere to see if any scar tissue around it. This is as our role. I mean, is from the clinical point of view is really significant. Okay. Now I give you.
Someone asked if
Oh.
you can repeat the snapping hip maneuver.
Okay. So, first landmark with the probe in the right position, maybe. Okay. So, for instance, it's very important that you keep this angle, okay? That oriented, because in a different orientation then become more difficult. You have this. The starting point is with the here, okay. Is with the you have to place the pubic rami exactly here, okay. Exactly flat. You see, parallel to the lower board, to the lower part of the screen, okay. And then you have the pubic rami, and you need also this part, okay, from the iliacus. Exactly. Okay. Once you have this, we obtain again this position, and of course, and the nerve is the tendon has to be really perpendicular to that. Once you have this position, okay. Sometimes it's not easy, but it's very okay. Here, it's very important to have the probe like this. Then you start to flex. Flex. Always keep the tendon hyperechogenic. Keep it hyperechogenic. If not, is easy to lose that. Go up. Hyperechoic. You see where it is now? The tendon is very superficial. It's just up there. Exactly. You see this point. When you have this point, you start always keeping the tendon as much echogenic as possible to abduct, dextro rotate, here, exactly here, and then relocate in the position, in neutral position. You see this is maneuver. So the maneuver, abduction, extra rotation, and then slowly relocate. Always pay attention to tilt the probe during the entire arch of the movement. If not, you miss the tendon. Okay. Okay. Yeah. Yeah. It's interesting for the block in case of. Can you? I give you all the paper. Thank you. So the genital nerve are interesting for because I know that are spotted for the injection in case of advanced arthritis, just to keep under control the symptoms. And we have 4 genital nerve. We are the supromedial, infromedial, superolateral, infrolateral. The most common, it's sufficient to inject 2 or 3 of them, and not necessarily all of them. So basically, the first, much easier to find, is the infromedial. The infromedial, you start from use as a landmark. You can use it as a landmark the medial collateral ligament, and you go distally. You see that there are small vessels here. These are the genicular vessel with the genicular nerve around it. This is a good spot where you can inject. Okay, so it's basically just underneath the superficial component of the medial collateral ligament. These are, the structure or the pes anserinus tendon here that then go to insert on the periosteum, the tibia. So just go up and just cranial to the pes anserinus underneath the superficial component of the medial collateral ligament. You have the infromedial geniculate nerve and vessel. Okay, maybe if we use the other probe is. You can see even better. They are really huge, okay? These are the vessel close to it. You have the small nerve. Like this one. It's sufficient that you aim in this area, okay? It's not necessary that you see exactly the vessel. The branch you see here is from the saphenous nerve, just for curiosity. Okay, again for the saphenous nerve, just to show you that the cutaneous branch, of course, are everywhere, and sometimes when you have some scar tissue and you don't see exactly the main trunk enlarged, consider that there are these small branches that are not well visible but could be really painful. Okay, this is the infromedial. The supromedial is you just go up. You look for this level. Okay, basically you have to go back again to the thank you, because the supromedial is require a bit more in depth, a lower frequency probe, so you can look for that here. This is the spot. Again, you have the vessel. You have the genicular vessel, and close to the vessel, you have the nerve. Is a quite safe approach again. Okay, so this is the supromedial. You look for the femoral medial condyle. Go back along the slope, of the femoral shaft. You have the vessel in between the vastus medialis and the bone. Okay. Then the lateral one, the supromedial, is almost specular. Is almost specular to the supromedial. So again, I look for the femoral condyle here. You see the vessel just here. Okay, a bit more superficial. Here. You can and you can follow it. Okay, this is one. The infrolateral usually are the ones that are less frequently blocked because they are a bit more difficult position. This is the fasciolata that go to insert the Gerdi tubercle, and usually the nerve go very close to the meniscus, This is the point where you have the inferolateral. Okay, there is the fasciolata here that is a bit harder to pierce, so usually is left unblocked, but is in this case anyway you can find it very easily. Okay, it's close to the lateral meniscus, underneath the fasciolata, and you have this coarse vessel with the nerve around. Okay, these are the 4 spots for the geniculate nerve. Okay. So now just a quick look on the lateral side, because I think that up to now we don't have been not demonstrated. If you can go a bit more lateral, is possible. Thank you. And with the leg distended. Okay, thank you. So lateral hip basically means trochanteric syndrome and pathology around the greater trochanter. Okay, so basically what I do when I examine the greater trochanter is to recognize first to recognize the greater trochanter in all these aspects. I mean, is usually as this. Okay, usually as the shape with an anterior facet, lateral facet, and a posterior facet. Okay, and for all of this part of the trochanter, there are different structures that go to insert. On the anterior facet, you have the insertion of the gluteus minimus. Okay, that you can usually here you can study it. Both of course in cross section, just a little the insertion here, but also in longitudinal axis could be studied, could be done. And for the longitudinal axis that you see here, the probe is a real oblique. Okay, because the tendon is really an oblique inclination. You see here like this. You see the to be sure to be in long axis of the tendon, you have to see the intertendinous aponeurosis, intermuscular aponeurosis. Okay, when you see that, you're sure to be in the long axis, and could be useful because you know that all the tendon of the that got inserted on the trochanter have their own bursa. Okay, there is the proper bursa of the gluteus minimus, proper bursa gluteus medius, and so on. And the bursa usually is located where the nerve go to scratch against the bone. This is the point of the bursa. Okay, so with this view, you are able to identify if there is any any fluid collection, fluid distension of the bursa. Okay. For the lateral, on the lateral facet, we have the insertion of the gluteus medius with two components. One is lateral, that is quite thin, and one is posterior medial, that is this one. Okay, that is much more thicker. Okay. And again, also in this case, I study both in long axis, in longitudinal axis, like this. And again, this allow me to check if there is any gluteus medius bursa distension over there. And more posteriorly, look at the posterior superior component. Okay, this is much more thicker, and is really huge here. Okay, thank you very much for just here. This is the posterior superior component. Okay, so two tendon, one slender and thin here, the lateral component, and one much more thicker, the posterior superior component that go to the posterior superior facet just here. Okay, and if sometime in the lower part, this one is the piriformis. This is the piriformis muscle. Okay, the piriformis tendon on this one, in the depth that go to insert on the trochanteric fossa, but we can see better in the posterior aspect. Okay. So where is the bursa? The bursa is located. When you look for the bursa, you have to look superficial to the gluteus medius, and sometimes the fluid collects just posterior at this level because it's the space where there is a lower resistance. So when there is no big trochanteric bursa distension, just look to the posterior aspect to see if some fluid, some synovium collect on the posterior side of the trochanter. Okay. And that's all for the lateral hip, because regarding to the fascia I already talked before, and the possible impingement, possible snapping over the trochanter. Is there any specific question for the lateral hip? Okay. Well, of course, basically when you see a swollen hypoechoic muscle, you try to look if there are some interruption, and the best way I cannot perform dynamic maneuver for that, and but if you place the leg in extension in this position, is already the tendon are already very tense. So if there is any partial rupture, any discontinuity inside the tendon, you are able to see that. Okay. This how I do, yes. That of course, as you know, is the main cause of the trochanteric pain. Okay. So now we check if you don't have other question related to the lateral hip. We check the piriformis, and even we have seen that there is no much pathology to see about that, but just to recognize maybe for injection. Okay. Thank you. Sorry, but you have to go further up. So one effective technique to me to recognize the piriformis is and the other structure is as we seen before, that we can do that as with the linear probe, not only with the convex probe, is to look to go very up in the super internal part, just up to see the sacroiliac joint at this level. Okay, this is the aspect of the iliac bone, just here. The vessel you see here in this point is the superior gluteal artery, with the close, of course, as always, the superior gluteal nerve. That is quite important because innervate gluteus medius, gluteus minimus, and the tensor fasciae latae. And then I go down until the bone wall disappear. Okay, once I'm here, this level, just grab the leg like this, and I perform internal and external rotation like this, and so the muscle moving in that position is the piriformis. Okay, and underneath the piriformis, underneath the piriformis you have the sciatic nerve in just before it exit there. Thank you. So this is the technique to see the sciatic nerve, the piriformis, and then when you go down, when you go down, this is the sciatic nerve, and just to recognize, when you see the big tendon here, this is obturator internus. Okay, and it's useful because where obturator internus come out is the lesser sciatic foramen. Okay, This is the point of the lesser sciatic foramen. This is also the point where this is ischiatic spine. It is useful because it's the point where you can inject for the pudendal nerve and artery. This point. Okay, so find that the big tendon is the only big tendon that is underneath the sciatic, you see? Because the gemelli muscle just form a unique tendon with the obturator internal. So you check for the sciatic, find the tendon, move immediately, and look where the obturator internal muscle go inside the pelvis, and you have the spine, the sciatic spine with the pudendal artery, pudendal nerve just here. Okay, and if you go down, instead of when to check for the pronator quadratus and the other muscle, so we have the sciatic nerve here. Then I go down on this level, and when the next muscle I found at this level is the pronator quadratus, and it's very useful, this position between the trochanter and the ischiatic tuberosity, because also is a good marker to see if there is any ischiofemoral impingement. Okay, I mean, of course, it's difficult to perform the dynamic maneuver for the ischiofemoral impingement because it's difficult to grab the leg and taking in a position. But if there is any bursitis, you can find that. And of course, there is also some paper that said that, they measure the distance between the tuberosity and the tuberosity and the trochanter. Sorry. Okay, thank you. And if less than 2 centimeter is, I mean, it could be a sign of ischiofemoral impingement. Okay. And the last thing, when you are a level of the ischial tuberosity and you look over it, and this point, this is the point of the inferior gluteal artery and nerve. Okay. At level there is tuberosity, you look at this area, this is point of inferior gluteal artery nerve. Okay, here that go to innervate the gluteus maximus. So we have a gluteus maximus innervated by the inferior gluteal nerve, and the gluteus medius innervated by the superior gluteal nerve that exit at the level of the greater sciatic notch. Greater sciatic notch. And okay, I think that well, of course, there is sometimes you can have a pathology of the insertion of the gluteus maximus at level of the gluteal line at this level, and this is not a common finding, but moreover we used to do some sport like cycling, you can have some alteration at this point. This is the linear aspera of the femur, and this is the aponeurotic insertion of the gluteus maximus. You can have some alteration here. It's interesting to notice that when it finished the aponeurosis, the gluteus maximus, what start here is the lesser the biceps femoris, the lesser component of the biceps femoris. This is the long head, this is the short head that began when there is the insertion, the last part of the insertion of the gluteus maximus, just for you as a landmark. Okay, do you have something? Okay. Yeah, of course, does it change? Of course, and it could be also a dynamic maneuver to perform. In fact, when you perform in CT or MRI, sometimes it's much more easy, much more objectable, And but ultrasound, somebody said that you can also check for that. Of course, you have to the main findings when there is an impingement is alteration, kind of bursa, ischiofemoral bursa alteration that you can perceive in that area with ultrasound. Okay, and
Luego, por ejemplo, la fascia lata, ¿no? Cuando hacemos... Cuando, ¿me oís? Es decir, la fascia lata cuando estamos...
okay.
Cuando estamos haciendo la ecografía de la cadera lateral, en decúbito lateral, cuando tenemos la extremidad estirada, la fascia lata se comprime contra el trocánter. Entonces, y el líquido de la bolsa se exprime posterior. Si nosotros levantamos un poquito la extremidad, como para pinchar, ¿no? Esto es truco del doctor Valius. Ponemos una almohada debajo de la rodilla para levantarlo un poco o que alguien nos lo levante, la fascia lata no comprime contra el trocánter y podemos ver mejor el líquido de la bolsa. ¿De acuerdo?
Okay. Yeah, I understand. I totally agree. And yes.
Can you show us the reproduction of what the lateral impingement would be with
Okay.
the fascia lata and the...
Yeah. Yes, could you? Yes, again on lateral side. Yeah. Yes, could be.
Para ver los resortes de la cadera lateral. Y a veces el paciente es capaz de hacer el movimiento en decúbito reactivado, pero si no, yo lo hago de pie. Y si tiene que andar, andando.
So we look again for it over the lateral counter. This is main spot, and then you can flexion and extension is the best way to see if there is any snapping occurring over that maximal flexion with the fascia here, and again the extension with the fascia just here. Yeah, exactly. Glute major here, sorry. So is okay, glute major. This is the fascia lata, you see it very well here. And so you from extension here, you go in flexion. And you see that the fascia lata tended to move backward, but not much. In pathological case, in maximal flexion, you see the snapping. Okay, and but indeed, other than this maneuver, it's very useful to ask the patient to reproduce the fascia lata, because sometimes when they complain that they know exactly what are the kind of movement that they reproduce. Moreover, where they stand up, they all know how to abduct the hip just to make the fascia lata snapping. So it's also good before to ask them for that, to ask them to reproduce the snapping, and do you check with the pro. Okay. Where the anterior recess, but I don't think this. Just go back. As you prefer, is here. So this is the joint line. We recognize that very well. And for the anterior recess, we just turn the probe like this, according to the shape of the femoral neck, and we check at this level, okay, and we can see this is useful also to check if sometimes also for there are any kind of impingement, kind of pincer impingement. This is there are some paper that define the angle, you see both the alteration, you both can calculate the angle for the pincer impingement. Then you move distally, you see exactly here the recess, the anterior recess in this point, okay? And it's difficult to recognize the zona orbicularis, but more or less it occurs at the passage between the femoral head and neck. This is the area of the zona orbicularis. But of course, if you perform injection, you aim to the lower part of the bursa. This one is much easier to get in, and there is no much fluid distension. Well, in this case, there is no much fluid distension, but the thickness of the recess is only related to the fact that this is a twofold recess. Okay, so the two layers of the capsule are one over each other in this point, and these are the most superficial part is the fibrous part with the pubofemoral and the iliofemoral ligament. You see very well the fibrillar structure just over here. Okay, good.
Inserción, tendón directo, indirecto.
Okay, yeah. We said this morning, but repetita juvant, we say. Yeah, so okay, so as you can see, this is the best position to put the indirect tendon under tension. Okay, so the one leg over the other, and we look first for the rectus femoris, where we see the central aponeurosis of the rectus femoris, that we see that there is a small injury here. Then you follow up the central aponeurosis, follow up here. You follow it up until you see this shadow. Okay, when you see this shadow, you start to turn the probe like this, and to turn and go a bit more lateral until you see the insertion over the acetabulum. Okay, and in this point, and this is the shadow here, and over here like this. Okay, and this is the indirect part, and of course there is not only the indirect part, there is also the reflected part of the rectus femoris, but is not well visible with ultrasound. But it is relevant. This is the conjoined tendon in this point. Is relevant, the reflected part, even we are not able to find it, because I got to insert over the capsule. So when you have an injury of the indirect tendon of the rectus femoris, sometimes you have also a breach into the capsule, because you have a traction of the exerted by the reflected portion. Okay, and this is the tendon here in this point. Instead, this is the direct part that got to insert over the tuberosity, over the anterior inferior iliac spine. And we can check also in short act this level. Okay, this is the anterior inferior. Okay, you have the long axis of the direct origin, direct tendon of the rectus femoris. You see very well the shadow, the conjoined tendon of the part of the conjoined tendon, the shadow of the indirect, and then you can try to follow it in short axis. But moreover, if is normal, as in this case, is become very hard to find. Here, move. You have to move not only laterally, but also with the one edge of the probe to keep it a bit more a bit oriented toward the acetabulum. Okay, this is the point. Okay, from ear to ear. Here. Try to put the angle in just a normal, in neutral position. Thank you. Yeah, just become sometimes become less tense. Okay. You see here, you make a kind of notch in this point because it's more relaxed. You see, you do like this, and this here a kind of notch in this point, just to show the difference according to the leg inclination. Is direct part, origin of the indirect. It is alteration along the indirect tendon. Indirect tendon that could, this could be also some a previous injury like a scar tissue. You notice that sometimes when you change position is could be much more useful to enhance some subtle findings. Okay. Do something more? Some question? Yeah. The muscle and the tendon. Okay. Okay. So rectus femoris indeed has more than one myotendinous junction because he said that it's described as the indirect tendon. This is the point, the intermuscular aponeurosis in this point, and this also itself a myotendinous junction, but only for the indirect part. Okay, in the direct part, the direct tendon, it's been described as a myotendinous junction, just a very eccentrical, very superficial. That is at this level. Okay. Instead, on the lower level, you have the myotendinous junction in common with the vastus intermedius. Okay, so it's a quite complex muscle. So you have for the indirect part, the indirect bundle of the muscle, the myotendinous junction is around the central aponeurosis. Okay, and for the direct part, the myotendinous junction could be much more superficial, and for the distal part, we have myotendinous junction in common with the vastus intermedius at this part, in this component. Then, if you follow that. If you follow that distally, this is the distal myotendinous junction, and is interesting because within the quadriceps tendon, the layering of the tendon is preserved. I mean, the most superficial part of the quadriceps tendon is from the tendon of the rectus femori. The intermediate part is from the vastus medialis and vastus laterale. 1, 2. The lower part of the tendon, the quadriceps, is from the vastus intermedius. Okay, so it's nice to recognize all the different structure. But of course, when you have a lesion, in the distal part, you have no more the layering. But what could happen to have a very superficial partial lesion that usually involve the most superficial part that is from the rectus femoris. Okay, but what is very important for you is to see if the lesion is much or more than 50% of the tendon thickness. That could be significant from the clinical point of view. You see the most distal aponeurosis of the rectus femoris with the myotendinous junction, in common with this one, in common with the vastus intermedius. Okay, so yes, it's really a complex muscle where you can have different type of injury, and occurs more commonly along the central septum disease that is a real myotendinous junction for the indirect bundle. Okay. You're welcome. Any? Okay. What time is it?
Serán 10 minutos todavía, si quieres. Alguna-
Oh, it's okay.
The lateral side, sometimes you can see like another neurosis or
Could be.
Sí, pero o sea, tendón directo, tendón indirecto y tendón reflejo.
Yeah. The tendon.
Claro, pero con ecografía yo, el tendón-
Yeah, exactly. Reflexio is not.
yo personalmente no.
No. It's a. What I'm saying before that you know about the existence of the tender reflexus when you have a lesion of the indirect, that at the same time you have a breach in the joint capsule, because the indirect and the reflected are interconnected. Okay, so when you have a lesion of the indirect tendon, and you at the same time you have a pulling or on the capsule over the capsule from the reflected component, and so this can create a damage in the capsule and can create some fluid around that, because when the indirect tendon go to insert directly over the acetabulum, okay, and there is no sense to see fluid around the capsule. The fact that there is fluid, that means there is another component that anchor the indirect to the capsule, and it is the reflect. But it is an indirect sign, not a direct visualization. Okay.
Pues damos por terminada la sesión. Muchas gracias.
Thank you very much.